Now, the second part of these general principles of antimicrobial therapy. Now we can start after the empiric selection, empiric therapy. Second, uses against the important microorganism after getting culture sensitivity. They may be against any type, different types of bacteria may cause infection. They may be gram-positive cocci, gram-positive bacilli, then gram-negative cocci, bacilli, rods, etc. There may be aerobic and anaerobic organism. So there may be spirochetes, mycoplasma infection, chlamydia, and so many other microorganisms can cause infection. Accordingly, we can select the drugs which are specifically effective against those infections. Narrow spectrum agents act on a single or limited group of organisms. For example, against the mycobacteria, isoniazid, for example, against the antitubercular drug, as antitubercular drug, only against the tuberculosis. No other effect we have seen anywhere. Similarly, extended spectrum agents which may be effective against a variety of gram-positive and many gram-negative organisms. So, for example, gram-positive bacilli against Listeria, monocytogenes, etc., gram-negative rod, E. coli, Haemophilus influenza, Proteus, Salmonella typhi, paratyphi, etc., etc. So, their spectrum has been extended. Here, one of the important example is of a penicillin, especially ampicillin, amoxicillin. Then there is broad spectrum. It is more than the extended type against the wide variety of microbe species. For example, tetracycline is a broad spectrum antibacterial. Not only gram-positive, negative, bacilli, rods, etc., also against actinomyces, rickettsial infection, amoebiasis, etc., etc. So, the only problem is with this broad spectrum antibiotic is they may cause superinfection. We will see what is superinfection later on. Third is the prophylactic. So, let us take some example of the prophylactic use of antimicrobial agents. So, for example, in the rheumatic heart disease, because it is very common streptococcus infection in the young patient with the history of rheumatic heart disease can be affected. So, here usually long acting benzathine penicillin is used, which may be continued for years or years prophylactically. Or before the dental extraction, prophylactic treatment is given to prevent the bacterial seeding in the artificial parts of the patient. So, usually it may go into, it is very common with the artificial tooth having person, infection may go from here to the, especially if artificial heart means some prosthetic valves are there. Some patient like tuberculosis or meningitis, they may show some other infection also, so we can use prophylactic. For example, patients or attendants handling the tubercular patients or meningitis. So, all attendants or close relatives may be given some drugs to prevent them from infection of tuberculosis or meningitis. Prior to surgery, as we have seen so to prevent the infection, patient undergoing like bowel surgery, joint replacement, some gynecological intervention, etc., etc. Here, then HIV pregnant mothers. Actually, here we want to prevent the fetus. Mother is already infected, but we want to prevent the fetus. So, HIV infected pregnant women are given some prophylactic therapy so that the fetus may be prevented to get these HIV infection. Then the fourth use is inappropriate use, non-proper use. For example, use for untreatable infection. For example, viral infection like in measles, mumps. So these are the viral infection. So in viral infection, antiviral are used. There is no need to use antibacterial, but still we use. Then what is the idea behind that? Idea is usually what we have seen, that these patients who have got viral infection, due to some problem, they may get along with some this condition bacterial infection also. So to avoid that, we can use prophylactically actually these antimicrobial agents, antibacterial. Similarly, a patient suffering from fever, long fever for days and weeks, and no proper reason have been isolated or have been detected. So fever of unknown origin. It may be per short duration like viral infection, or infection with prolonged fever like tuberculosis, and we are unable to diagnose that tuberculosis, or some hidden infection, some abscess is there, intra-abdominal abscess, subphrenic under the this diaphragm, infective endocarditis, or some cancer condition is there, some hepatitis there, or some atypical rheumatoid arthritis patient is there. So fever may be due to so many reasons. But don't forget, okay, there may be some drug-induced fever also. So there we have to stop the drug then. Possibly the improper dosage is given due to possibility or some concern about the possible toxicity. It's very common. Usually patients are taking under dosage drugs. So that lead to produce treatment failure. Or this improper dosage along with selection of resistant strains may be there. Okay, we have not selected the drug according to the culture and sensitivity. Instead of that, we have selected such a drug and we are using higher dosages, but the patient is suffering from infection due to resistant strain. So instead of getting the treatment of infection, we are getting the adverse or the toxic effects of that higher doses of antibacterials or other antimicrobial agents. There may be inappropriate dependence on the chemotherapy. Some disorder requiring both chemotherapy and a surgical procedure like pneumonia with empyema, they may be managed by drainage instead of prescribing the chemotherapy or chemotherapeutic agents in such patients. So there is a rule: abscess anywhere, drain it, incise it and drain it. Then you can use chemotherapeutic agents. There may be some inadequate bacteriological information. For example, without microbial data, clinical judgment is only on which we are depending and we are selecting drugs, just like empiric therapy. So antimicrobial therapy must not be based on prescribing habit alone. It must be individualized. We must get culture sensitivity test of that particular patient. Then the combination of antimicrobial drugs is very common. Rarely we use single drug. We usually combine different types of antimicrobial agents. Advantages of drug combination is, okay, with infection of unknown origin, we can combine beta-lactam, which are cell wall synthesis inhibitors, along with aminoglycosides, which are inhibiting the 30S ribosomal units. So they show synergistic effect. Synergism may be there. This is the advantage of combination. Disadvantage may be, okay, we can combine bacteriostatic with bactericidal. Remember, we have seen previously, bactericidal shows effect only when the bacteria are dividing, while bacteriostatic stop the division of the bacteria. So in combination, Bacteriostatic will stop the bacterial division, so bactericidal cannot show their effects. So in this way, interference with the action of each inhibition. So tetracycline may interfere with the bactericidal effects of penicillin and cephalosporin, etc. So don't combine these tetracycline with the bactericidal like penicillin, cephalosporins. This is the viva question and the MCQ questions also. Another combination is to prolong the duration of action. For example, the first example, duration of drug can be prolonged without any combination just by using the higher dosages. Second, with the combination of probenecid. Probenecid usually uricosuric agent. It is allowing more and more uric acid in the urine and via uric acid. So if any other acidic drug like penicillin is an acidic drug we are giving, so it is not allowing the excretion, so it is retaining inside the body. So more and more level of penicillin will be seen with the probenecid. In this way, we increase the level and duration of action. Third combination is we can add other drugs also to prolong the duration of action. For example, we can add procaine. It can increase the duration of action of penicillin instead of for 3 to 4 hours up to more than 24 hours. Or we can combine with the clemizole, even double that, about 2 days. Or we can combine benzathine. It can increase the duration ranging from how much we are using benzathine from 1 week to 4 weeks. Usually this is in a depot form. As we have seen, we usually use these drugs in case of children suffering from this rheumatic joint disease, in which there is very much strong chances to get rheumatic heart disease. So to avoid the patient to get that rheumatic heart problem, prophylactically we are injecting once a month injection of benzathine up till about 16 to 17 years of age. There may be some unpleasant adverse effects also. Simple dizziness, mild abdominal discomfort, pain in abdomen, mild vomiting, loose stools, to mild diarrhea, etc., etc. Second is superinfection. We have seen previously while we discussed the broad spectrum. So basically, this superinfection is seen with the broad spectrum antibiotic. Superinfection is the infection of the opportunistic microorganism. Opportunistic, which are just waiting for the opportunity. What opportunity? Whenever there is any immunodeficiency is there, number one. Or number two, there is damage to the normal bacterial flora, which is having actually probiotic effect. When there is damage to that bacteria, immediately these opportunistic microorganisms produce their infection. This is superinfection. So actually there is alteration of the non-bacterial flora of 3 sides. It may be of the upper respiratory tract, of the intestines, or the genitourinary tracts. So superinfection can occur in these 3 sides mainly. So due to alteration or the damaging of the normal bacterial flora, they permit the overgrowth of the opportunistic. opportunistic microorganism, and this is usually the fungal infection or some infection due to resistant bacteria, Clostridium difficile, etc. This is the example of that. Clostridium difficile may produce pseudomembranous enterocolitis, and this is known as antibiotic associated enterocolitis. And the very important, as I told you, is the development of the resistance against this bacteria. Bacterial growth remains unaffected then. Some of the bacterial strains may even become resistant to more than one antibiotic. Now, mechanism of resistance development during antimicrobial use. What is the reason how resistance develop against microbacterial agents? Now, reason may be there of this resistance. First is the genetic alteration. There may be some simple spontaneous mutation of the DNA or some DNA transfer of the resistant material from one bacterium to the other bacteria may be there. In this, there may be spread of resistance to other bacteria. Or there may be altered expression of the proteins. Some microorganism produces enzymes which can destroy the drugs. For example, beta-lactamase enzyme. We may call them as penicillinase or cephalosporins specifically, which may be against which destroy the penicillin or cephalosporins. These are produced by the microorganism and they destroy the drug molecule. And third one is the alteration of the structure of the drug, loss of some specific proteins. We will see later on with the different protein synthesis inhibitor drugs. Or there may be alteration in the metabolic pathway, alteration in the like in the synthesis of the folic acid synthesis. There may be overactivity of the efflux pump. Usually efflux pump is a less potent and less common cause of resistance. Or DNA. This is the one of the strongest site where resistance develops. So, mutation of bacterial genes for binding sites, they may cause resistance in the development. For example, as I have given you example, drug resistance due to enzymatic inactivity beta-lactamase as penicillinase, they destroy the beta-lactam nucleus. And common bacteria are Neisseria gonorrhoeae. So, usually up to now we have seen a resistance to penicillin because of penicillin's activity. Similarly, change in the permeability of the drug due to increased accumulation, tetracyclines especially. So, previously was effective against gynecological infection due to bacteriids, but now due to this problem in the change in the permeability of the microorganism, resistance developed due to the presence of plasmid mediated protein that promote efflux of the drug. So, difficulty is there in the accumulation of the drug. Proper amount or concentration of drug is not getting accumulated there to show any antibacterial effects because efflux pump is more active. So, some beta-lactam we have seen beta-lactams enter gram-negative cells through porine channels. So, Enterobacter is largely resistant to cephalosporins by producing beta-lactamase. However, resistant organism may also have been altered porine channels through which cephalosporins do not pass. So, apart from the beta-lactamase enzymes, second mechanism of resistance is this porine channels alteration, which lead to produce more and more efflux.